Thank you for the welcome. Appreciate being invited to speak. Thank you so much. Okay. Yeah, well, I'm going to talk to you about the new plague, and it's going to get worse because we've got some new things that the CDC is coming out with. I'm going to have a bunch of slides from me and from the CDC. And when you're done with this, I'm sorry, you're going to know about lab testing more than your clinical physician usually does. Okay? So, a lot of these slides are now from the CDC. I was out at Fort Collins about 2 months ago when a friend of mine retired. And I got a bunch of the slides from there. The CDC now says there are at least 14 diseases we know are carried by these ticks. Everything from Lyme disease, the Anaplasma, Babesia, all the way down to Powassan's and tularemia. We now know that there are 6 different ticks that can carry these diseases. Okay, you can go from the Lone Star down there on the bottom, or in the middle of the thing, to the deer tick up on the right side, the Scapularis. The one to the left is the Pacificus tick. Then you've got the Hermsii down in the middle, and a couple other ticks that we're all wonderfully becoming too familiar with. In Minnesota, you have about 12 different species of ticks. These 6 are all here. Okay? This is the one I'm going to call your most attention to because of the problem it's now causing. The Orthodontus hermsii tick lives at about 500 feet above sea level or above. It is an epidemic of hermsii that it is carrying with it. And yes, it transmits hermsii in between 15 minutes and an hour, so it doesn't take hours and days to transmit it. It is causing a significant issue in the western half of the United States. Of course, this is an adult deer tick, so you can, unless you got great eyes, and I don't, it's hard to see them. So, have we got ticks in the next state over? Yeah, 21% of the ticks had Lyme in 2010, according to the University of Wisconsin study. And in 2013, it was already over 50%. Ticks bearing Lyme in Iowa. By 2013, 23% of the ticks were carrying the bacteria. Here in lovely Illinois, next state over, again, you can see all of the green having a distribution of Ixodes scapularis, the deer tick. And here you are today in lovely Minnesota. 40 to 60% of the ticks carrying, according to Russell Johnson now at the university, are now carrying Lyme disease. So what that means is when you pull a deer tick off of you, you've got better than a 50% chance that it has Lyme. Okay? Now, what happens when a tick attaches or when it becomes life? First thing is a male-female tick get together, usually on what we call a Mediterranean cruise, which is actually a deer. Early in the fall, they fall in love. She ends up having about 2,000 eggs when she falls off and dies. Now, those 2,000 eggs turn into larvae as soon as the temperature hits about 30, 35 degrees. So you've got a lot of deer ticks running around, and that larva usually goes looking for this, one of these, and trying to transmit the disease. But the transmission time for hard cell ticks can be multi-days because there's a cytokine transmission that has to be taking place. But for the soft shell ticks, such as that, the hermsii, it's 15 minutes. So what is the major vector here? Well, that ticks usually come to life as larvae, and they go looking for the closest hot, warm body they can find, and those are almost always a white-footed mouse. That's why it's called the main vector. At any one time, if you find these mice running around your yard, you can expect to see 10 to 20 ticks on it if you could see them, and their larvae usually around the ear. If one of those ticks ever had Lyme, they pass it to all of the others. So you go from 1 to 20 pretty quick. And here's something that's happening that we found out at the University of Illinois. They are finding 27% of positive ticks on these cute little voles in central Illinois. And I'm pretty sure you got these little things running around here too. So yeah, everything you look at that moves, these things are going to attach to. And what do they do when they get inside the body? This is not Steven Spielberg. Those little white things are Borrelia burgdorferi moving through the system of a mouse. You can see that the part's pumping, but that cute little spirochetal shape is keeping it ahead of the immune response. So it can go and hide, find a nice warm place to live, and proliferate. So what we want to do is arm our mice, okay? So if we give them all guns, we're going to have a good chance, but the government doesn't like to do that. Mice only live to 2 to 3 years of age. We don't want to give them guns at that age. So we have a problem, and these mice run amok with deer ticks all over them in Lyme. Now, when that tick falls off after its first blood meal, it has 3 in its life cycle. Its second one is usually as a young adult, as a nymph. It goes looking for something bigger to attach to. So it'll attach to a squirrel, it'll attach to turkeys, it'll attach to lovely raccoons, and to birds. So they'll bring it all over the place. They'll bring it in your house. That poor little dog has a palsy in its head, but that cat's not happy at all for having Lyme disease. So yes, they will bring it into your house on a regular basis. I once had a resident call me from down in Westchester County. He'd been up at Yukon with us, and he called me and said, Bob, I got this little old lady. She's been bedridden for 5 years, and all of a sudden she's getting worse. We don't know what's going on. We've been treating her for rheumatology, and so I just asked her some questions. Does she have any pets? At which this kid knew me and started to swear at me. He says, yeah, she's got a cat. I said, where's the cat? Sleeps on her bed. And the cat had ticks all over it, and it passed Lyme disease to this 75-year-old woman. Luckily, we were able to get her off of steroids and put her on a high enough dose of doxycycline, and she got better. So then we put her back on steroids. But remember, pets are a real issue. They will bring Lyme into the house. How bad? U.S. canine positivity results, anything that's dark green has got a problem, okay? You're looking at 1,000+ animals that have been diagnosed with Lyme disease in them. These are the pets that come into your house, live in your yard, and they've got Lyme disease and they've got ticks all over them, and you're bringing them into your house. So we have a problem. When the rate of infection in those pets becomes 16% or higher, you are heading for an epidemic for the humans. And yeah, you already got that. This is what's going on in northern Illinois. It's bad. So I put up this one to scare everybody because these ticks will attach to anything. I hate snakes. I'm terrified of them. Well, this guy had about 35, 40 ticks on its head. The tick will attach to anything it can suck blood from. Okay, and it means these guys and these guys. This is why we call it a deer tick. This is a lovely deer. This one was actually out on Shelter Island. The Department of Health took it down, started counting ticks on its ears, stopped at 375 on one ear. Your average deer will carry a minimum of 400 to 500 ticks at any one time. They do not take baths, okay? They are going to bring those ticks into your, remember, they have about a 3 to 5 mile area that they will roam in their entire life. So they're going to go bring in some ticks into your yard, drop them off while they eat your arborvitaes and your flowers. Then they're going to go away, and the ticks are going to find their way onto mice, into your pets, and lovely. We have a problem. So what we really need to do, if we can, because of the 2 to 3 year life cycle of a deer tick, is actually to get our deer population down. But since 1900, we've done the exact opposite. 1918, it became illegal to shoot a gun within 50 to 100 yards of a home. In 1954, a guy named Disney made it socially unacceptable. And now we've got 35 to 40 million of these monsters running around. And your population is a problem because, according to the Department of Agriculture, 7 to 10 deer per square mile is good. Above that, you start to see starvation among the deer. You start to see way too many eating way too many flowers, and it's just not good. So what do you got going on in Minnesota? Well, you got 1 million+ deer. Yeah, they come to your house. They like the pool. And their population is growing again this year, so it's going to be, I did the quick math, you're now at 11.5 deer per square mile. That's if you include all the land in your, not where these deer like to go, which is to your pool, to your yard, near a house. Because a deer knows a hunter can't come hunting them if they're in your neighborhood. Okay, they can roam through your yard. They've got a gay old time. They're going to eat your garbage. They're going to eat off your bird feeders. And nothing can hurt them. Unless you got a dog that's, loose, but for the most part, you're going to have a problem. So look, don't let them in the house. I know they like spaghetti. No, okay? Don't give them a nice shade next to the fireplace. And for God's sakes, they don't sleep upstairs, ever, okay? Because this is what you get. You got a CDC map. Many of you have already seen this one. This is the most recent from Paul Mead's group at the CDC, and it's growing. This is the map he doesn't show you that I've got. that actually shows you where the CDC says it's going to get worse. Look at the circle. It's right over your lovely state. It's only going to get worse as Lyme disease continues to expand here. Infection rates are way underreported according to the Department of Health in Wisconsin. Illinois, look at the numbers going up. Their tick-borne it's record levels. Deer ticks are in 26 counties. And your lovely state had well over 23 cases per 100,000. You realize that the CDC says an epidemic is 25 cases per 100,000 of any disease. You are fast approaching that. And actually, if you took the probability cases and not just the 1,300, bingo, you're over 25 cases per 100,000. You have an epidemic of Lyme disease. So, to add to the problem, we now know there are at least 27, 28 different species of Borrelia floating around. About 18 to 20 of them can be in your body at any one time. They do go into people's bodies. They don't cause a lot of problems, but there are some that do. And there are 7 of them that we know of so far. Okay? The one that Willie named, they named after Willie Bigdorferi, the original Borrelia. Then there's the Lone Starry, we used to call it Ed Masters disease. Then there's the 2 European strains, which are here in full swing because people seem to like to go to Europe and birds seem to like to fly. And of course, we've got a strain named 3 years ago by the Mayo because they found Mayoni, so they named it after themselves, being the, the shy people that they are. And we've got the Miyamotoi strain and the Hermsii strain. Hermsii is west of here. Miyamotoi is east of here, but I don't think so anymore because both of them are here. Okay? So why is this bug so hard to stop? It's only a bacteria, right? We got to be able to take care of that. As she explained, I have a molecular biology background. Since 1991, this bug it has outsmarted me and most of us every chance it can. And it does a good job. It's because it's so big. It is 970 million base pairs. Your human genome, those of you who watch The Big Bang Theory, see that thing on the left there. The human genome is about 4 billion base pairs, a little less than that. This thing is 1/4 the size of your genome. It has 123 genes that we found on it and 26 plasmids. The doctor who tries to compare this to syphilis, syphilis is 7 genes. That's like comparing a kid in T-ball to Derek Jeter. This is by far the smartest bacteria we have ever seen. It has been around forever, and it will outlive everybody in this room for sure. So what does it do? Why is it so smart? Well, here it is in living color. That's Borrelia Bigdorferi, those green things, in the mouse, on the blood system, and watch what this guy's doing. It's using its spirochetal shape to dig out of the blood vessel. So what it does over the course of weeks and months in your body is it digs out of the blood vessel using that nice spirochetal shape, corkscrew, to go in and out and go hide in the tissue. Yeah, it's pretty smart. So an old colleague I used years ago, Alan Steer, who named this disease after 1983 when he found all those kids in Lyme, Connecticut. He was a resident down at Yale in rheumatology. And over the course of a couple of weeks, about a dozen kids more came in from old Lyme, Connecticut, down to St. Raphael's Hospital. And they kept dragging him down because he was a resident, and he just didn't know what to call it. It wasn't Lyme. These kids weren't getting Lyme arthritis at their age. They didn't have that many cases in the entire country, never mind a dozen of them. And so he named it Lyme disease, ruined all the prices of homes in Lyme. So when he did that, this is one of the studies later on where he actually saw IgM response late in the disease. I put this up because many of your infectious disease doctors like to call IgM positive post-treatment Lyme disease syndrome. BS, okay? This is the only IgM bug that they test for that they say isn't active at an IgM infection. It's live. It's a bug, okay? So when you're going to have an IgM positive from any laboratory, it's an active infection for Lyme disease, as it is for any other disease that they deal with. Why do we know that? Well, this is 2002 Stevenson study showing what quorum sensing is, which is the ability of this bug to change its surface proteins over time. So what happens is that bug comes out of the tissue. When it comes back, your immune system will read the proteins on its surface. So what they do is, if the bug changes those surface proteins or folds over on them, your immune systems, your T cells, your B cells, see something that they didn't recognize. It wasn't the bug that drove them at the beginning. Now they've got a new bug. They give a new IgM response. So that's why we see IgM late in the disease. It's called quorum sensing. This is the first publication on it from Stevenson at University of Kentucky. There's been about 100 other publications on it. Now, Immunology 101 that your doctor learned in school was that in the first couple weeks after a bite, you get an IgM response. Your body starts to produce antibodies from a B-cell response, and oh boy, here it comes. You get a nice IgM early on, then that drops off, and you get an IgG, which lasts supposedly, and we know, for 3, 4, 5 years or longer, where your body's memory system in your immune system looks for and keeps an eye out for this disease. The problem is that if it keeps changing its surface proteins, all the IgGs aren't looking for those. It has to keep rebuilding an IgM, and what happens with your immune system, we know that one of the interleukins that causes what we call your immune cascade to take place, Borrelia goes around the back of your immune system and shuts down interleukin 10. When it does that, your body's immune system starts to get weaker. As it gets weaker, it can't produce antibodies, and it can, and it can't, and it slows down, and then the opportunistic co-infections show up. This bug starts to come back and become more prominent, and that's why many of you don't just deal with Lyme disease after a year or two. You're dealing with a lot of other problems, and you just feel bad all the time. It's because your immune system is being shut down. Now, Immunology 101, because I give rounds at hospitals all the time, and residents love pictures. So here's Immunology 101 for Lyme disease, okay? A beautiful rash, the erythema. These are erythema migraines too, even though they're not super round. This is one. All of these people were negative by serology testing. You know that test that you walk in with your doctor and you go, hey, I think I have Lyme disease? And they go, okay, we'll test you. So we'll send it off to the major lab, to the hospital, to any other laboratory. We'll do a nice ELISA test on you, which is a screen test that they use in the United States called a titer or an ELISA. I'll show you the technique itself. And I can tell you that every one of these people were negative by lab tests. So if your doctor was making a clinical diagnosis of Lyme and then being the good doobie he is following his insurance company and his hospital's requirements that he order a lab test to confirm his clinical impression, he's going to get a negative lab test. So if he's going to rely on the lab test to make the diagnosis here, these people are in trouble. And these also, oh, by the way, we all knew this was Lyme disease because if you really don't like your patient, what you can do is take what we call a puncture biopsy, and you can do PCR at the site of the bite. And then we find the DNA of Borrelia. We know it's Borrelia burgdorferi, one of the sensu lato strains. It's right there. And none of these tests came back positive serology. Every one of them came back positive by PCR. And again, PCR positive, serology negative. All of these PCR positive, negative by serology. I try to impress upon physicians not to do that. When you see the rash, do not do a lab test. When they see the rash, you get treated. You're in an endemic area, okay? If the person comes to the doc and says it's scaly in the center or it's painful, congratulations, that's probably a spider bite. Okay? So an old friend of mine, Joe Burrascano, stopped practicing a couple of years. He was out in the Hamptons. And he used to tell me early on that, you know, if you look at the person's ears, usually about 70 or 80% of them will have a red ear for the first month or so after infection, or around their nipple raised in red. Okay? Those are early signs of disseminating disease. Happens for about a month and it goes away. We don't know why it likes the earlobes, but it's one of the symptoms that we see, or physicians see rather, early on that go away. So the early symptoms of a clinical presentation, because this is supposed to be a clinical diagnosis, are the rash and the neck pain. A stiff neck is a significant issue, especially in midsummer. You're not going to get flu-like symptoms. No. It's more than likely in this environment a Lyme disease infection. Now, one of the other things Joe used to always say is have the patient take their temperature at 10 in the morning, then take it again around 3 in the afternoon. If they have a slight temperature in the afternoon and a subnormal in the morning, it's Lyme. Okay? Now, later on, the disseminating disease, the joint pain, if it's moving around. If 3 weeks ago you had a headache and now your knee hurts, your elbow hurts, your ankle hurts, it's moving around, it's finding a nice warm place to live and grow. And if it doesn't move, it's arthritis. That's the good news. If every night you get up and it always hurts in that joint, more than likely that's arthritis. Later stages, the neurological issues, especially with children, because you got kids who want to roll around on the ground, or you people want to camp out in the woods. You let these ticks get on you, they bite you in the neck. Borrelia has a wonderful affinity to the facial muscles, and it will cause a palsy. That's why we see it so often in children. And cardiac involvement, most of you don't know this, but 3 years ago, the CDC sent out a note to every board-certified cardiologist on the Northeast, and I think up into here, telling them that if they have any type of myopathy that they can't understand in the patient, any cardiac arrhythmia, they should be testing for Lyme disease, because it's a real problem. And yes, there have been a number of deaths, because Borrelia has a wonderful affinity for muscle, and it loves heart muscle. So let's go back in time, and I'm going to tell you why we in lab medicine have failed this so miserably. Back in 1994, I was invited to a meeting with a whole bunch of others of us who thought we knew something about Lyme disease. At that meeting, but put on by Astafeltwit, that's the Association of State Public Health Laboratory Directors, and the CDC. I was with the group from UConn. We couldn't sit with the guys from Yale, but what are you going to do? So we sat there, and they got up front and told us, okay, all you guys, you've been doing great jobs in your labs with hepatitis and HIV. We want you to use that same technique of a two-tier approach for Lyme disease. Now, our group at UConn stood up. Even Gary Wormser stood up from his Westchester, and Alan, of course, stood up from Yale. And we all said the same thing. Look, these tests don't work. It's not like hepatitis and HIV where we don't get false negatives. But these ELISAs are horrible for Lyme disease. So they coined the phrase surveillance criteria. And if you go to the CDC website, that surveillance criteria, never to be used for clinical diagnostic purposes, is still there. How bad is it? Well, in 2013, Lyme disease was the 5th most reportable. But if you add the 0 like the CDC says you should be, oh boy, it's approaching chlamydia. Okay? Because we now know there are at least, oops, they made a mistake. They now know there were over 300,000 cases. So this is the estimates, according to Paul Mead, that you've all heard about, that Lyme is endemic. We already know that. But here's his, I call this his hubba hubba slide. This is, I'm going to dance around this problem. And Paul Mead put this up to a group of us at Mass General a couple of years back, last year, when we were there at a meeting, and explaining how surveillance criteria, the two-tier approach, should be used. And it is only for surveillance criteria, so that it's that little tip of the iceberg. Don't pay attention to this. Just look at this. That's surveillance criteria. So it's not supposed to be used for clinical purposes. I put this one up because this was another slide that Dr. Mead was using, and it actually has showing a CDC slide. That Western blot's an IGeneX Western blot. He used it for his slide, showing how good a good Western blot is, even though he doesn't believe in IGeneX. So the problem with the two-tier approach, according to Jennifer Halsey, who heads the Arthropod Disease Program for New York State, is that the antigens we're looking for aren't necessarily the right ones, and I'm going to talk to you about that. First 30 days, too many testing being done, shouldn't ever be done in the first 30 days after a bite. And if you've ever had a vaccine or antibiotics in the last 3 to 4 or 5 years, you're probably going to have a bad first lab test. And that's just about everybody. So I went back to the CDC and see if they've changed anything. Well, this is their most recent 2018 Lyme case report that doctors are supposed to fill out. The front looks pretty good, but if you turn it over, there's a line there that I've got underlined that you can't read, but I put it out there. It should be emphasized that this epidemiologic case definition is intended for surveillance purposes only. So they want you to report it, but it is for surveillance criteria. It is not for clinical diagnostic purposes. I can tell you that every hospital in this state and in every state in the country uses it for clinical diagnostic purposes, a two-tier approach. So, doctor's got a problem. Looks like Lyme, feels like Lyme. I do what the company tells me I got to do, what my hospital tells me to do, what my IDSA guy tells me I got to do, all my bosses, and I do a lab test that comes back negative. Now they got a problem because they got to do something. Now, I put this up here because a good friend of mine, Richard Horowitz, has a questionnaire that's on his website, not only in his book. So if you want to, you can download it. It's about 5 pages long. I tell physicians to do this all the time. It actually explains MSIDS, which is the multiple system infectious disease, which means all of the diseases. It actually looks at the symptoms, and you fill it out, and it codes it up, and it gives you a number to see if you have Lyme or not, and it gives the physician a good indication of the whole person and where they stand instead of trying to just look at one little piece of it. So the MSIDS questionnaire is free. Richard's got it up there. We've got one at our website if you want it. I always push people to Rich. He's a good guy, and I like his is more in-depth than ours. So the problem the doc's got is not a 300-pound gorilla, okay? The problem is sitting next to it on the bench. That's the tick, okay? So they got a choice here. And this actually, there was a lab name here, a major one that only had 4 letters here in Minnesota. And it actually said that lab. And I took that out of respect for the laboratory because they do a lot of good work. They don't do any good work in Lyme. So, but this is what happens when you get to your infectious disease doctor. How dare you show up? We get you a negative lab test, put on your clothes, and go home. Well, you got all these symptoms. There's a problem here. Don't send me home and tell me it's all in my head. Well, it could be in your head because neurological Lyme does happen. So it could be there. More than likely, it's Lyme. So you got to choose. Doc's got to make a choice here. Now, he can goose step with the rest of the boys with the IDSA and say, okay, look, we're going to put this little disease right in a box. The only by the way, it's the only disease they do put in a box where you treat for 2 weeks and you're cured. But regardless, they diagnose it as a rash. It's got to be there. You've got to have a 2 positive test. You got both of those. If you get through all of these hoops, which most people can't, then you've got Lyme disease. We'll give you 2 to 3 weeks of low-dose doxycycline, an antibiotic that's at a bactericidal, static dose, not cidal, and you're cured. And after that, if you have a problem, we'll send you to the psychiatrist. They'll take good care of you. And so we're an ILADS member, of course, and ILADS has a different attitude about it. Treat the people till they get better. This bug hides. It finds ways around. It is not easy to kill with low dose. It's too big, it's too strong, and it's way too smart. So they always hit me with this when I go to medical centers. We want evidence-based medicine only. Okay, I have 700 peer review articles showing that chronic Lyme exists. How many more articles do you need to show you that Lyme disease can be chronic? I don't know what they mean by peer review if this isn't going to work. So an old friend of mine who passed away a few years back, Ed Masters, he's the guy who found Masters disease in Cape Girardeau, Missouri, which became now known as Lone Starry Eye. He used to always say to me, Lyme's a clinical diagnosis till you make it. Then it becomes a political statement or take your license away. So let's talk about the immune system and why these lab tests miss so badly. We're just going to talk about the acquired, which is your T cell and B cell responses. Okay, we're going to start with the testing that we do for your B cell responses, which is your immune response by producing antibodies, because that's what the screen tests all do. They go looking with an indirect test such as an ELISA, an IFA, or a titer. I can tell you, having done a number of articles and looking at them over the years, that the sensitivity and specificity of these tests is somewhere between 50 and 70%. What that means, take a quarter and flip it. You've got just as good a chance of getting the right answer as the lab test from your local lab. Okay? Why? Here's what happens at a lab. There's a 96 well plate that we've got. Into that well plate, we pipette in your serum into 1 or 2 of these little wells. And then we take what we think are the antigens that are specific for the bug, and we put them in there. And then we try to get an immune complex to form, where the antigen that we piped in looks at your serum, and if there are antibodies that you've built against the bug, they bind. They form an immune complex. And if they form an immune complex, it's nice and strong, supposedly, and when it does that, you use a second antibody. Here's the problem. Lyme disease is the great imitator. So you have antibodies for every disease you have had for the last 3, 4, 5 years floating around. And the antibodies all looking for antigens. Well, the antigens that Borrelia has as a great imitator look like a lot of other diseases. So what happens is all those antibodies you've got in your serum try to bind to the limited number of antigens. And they can't grab on. They grab partially on. They don't bind fully. They've got like 3 or 4 different antibodies trying to grab onto one site. And you don't get a strong immune complex formed. third step at the lab is to do a wash cycle. And it washes away anything that isn't strongly bound. So all of a sudden, you may truly have Lyme antibodies floating around. They had no place to bind. Down the sink they go, as do anything that's partially bound. It rips it right off in the wash cycle and drops it down. We use a second antibody then, the fourth step, which is looking for the immune complex, and there aren't any there. Voila, you get a false negative. Does it work? Am I the only one saying the ELISAs don't work? No. The College of American Pathology, you know, there's about 20,000 of them in the United States. They have told us, and they continue to say, that the ELISA assays are not adequate to be part of any two-tier approach that the CDC wants. Here's a 2-year study from an old colleague, friend of mine, Steve Domler at Johns Hopkins. Steve just left there to go to the government to work. But in this 2-year study of about 1,700 people published in Journal of Clinical Microbiology, this was the original one. He did it 2 or 3 more times. They got the right answer using the ELISA test that you get from your doctor, that titer test, less than half the time. A metaphysical study just published in International Journal of General Medicine showed that the kits that everyone uses are right in ELISA test at the maximum of 62% of the time. And those are the kits that are used at every major hospital or laboratory in the United States. Because the kit's cheap, it's quick, and you can use a tech who isn't necessarily the best tech in the world to throw it into a machine, and you get exactly what you deserve. So one of the things that Alan Steer developed back when he was still at Yale was to do an immunofluorescent assay for this. And what happens is, what we're doing is we're trying to look for those surface proteins by taking your serum and literally washing it across a slide that's got the Borrelia on it. And what happens is, if you've got antibodies to Borrelia, they will try to bind to the surface of this bug. And if they form a strong immune complex and stay there through the wash, then when we hit it with a second antibody looking for that complex, it glows, and you get a positive. That's what an IFA immunofluorescence assay is all about. Does it work? Well, it's better than an ELISA, but then again, so is the quarter in your pocket. So its sensitivity is pretty good, specificity is fair. You need something much more specific than this. Okay? So we're going to talk about Western blots and where they are and why. In a state where it's endemic, I don't think any other test has up to now been anything near as appropriate. But all Western blots aren't alike. Here are all of the outer surface proteins that we have ever seen published on in the United States or anywhere for Lyme disease. All of this means is these are the antibodies on IgG and IgM. Remember, the IgM is the quick one and the late one, that have ever been associated in any major publication here in the United States with Lyme disease. Now, some of these cross-react. Most of them cross-react with other diseases. Remember I told you, it's a great imitator. So these other diseases' antibodies look for it too. So you got both. There are some that are very specific, but not many. Okay? So why is that? So how do we do a Western blot, and why is it so much better? Well, we take this big vat, or so does the commercial company that makes these kits for your labs. And what we do is we throw into this jello all of these antigens that we think are specific for Lyme. Then we mix them all up so they're nice and homogeneously spread. And then we cool it off. Put it between 2 pieces of glass, put it up on its side, take your serum, pipette it in on lanes 2 to 7. Lanes 1 and 8 we reserve for controls and CDC standards. And then that's what every lab does. And then we hit it with a positive charge. Positive charge drives your Borrelia or whatever's in there antibody down. Okay? So does the weight of it through the system. So what happens is I explain it like this. The bigger, chubbier guys, they're tired. They can't run through the jello. They just stop. But the lighter, smaller ones can go all the way down to get away from the heat at the top, and they run down. So we spread these antibodies out by molecular weight. Now, when you disconnect the power and you let those antibodies look for antigens that we've put in there that match them, or match Lyme disease rather, they will bind. They form immune complexes. We use a photographic plate. Every lab does this. When the photographic plate sees that binding, that blob becomes a band. So that's where the heavier ones, that's kilodaltons, down to the lighter ones happen. Lanes 2 through 7 are patients. 1 through 8 are 1 and 8 are controls. And that's what everybody does in a Western blot, okay? Now that can be magical and it cannot be, but some people don't know so much. Now, the original strain which Willie found was the B31. That's what all the publications were on. But at the meeting in Dearborn, the CDC also said there were 2 other strains that have a lot of publications. The N40 strain out of Westchester was in pretty good shape, and Golightly's group at Stony Brook was doing very eloquent work on the 297 strain. So the CDC said we could use any one of those in a laboratory here in the United States to perform as to use as the strain for looking for Lyme or the sensu lato strains. IGeneX, I'm going to kick here, we use 2 of the strains, the 297 and Willie's, and it gives us a better presentation of all the different proteins, because the proteins change on the surface over time. I showed you what it does. The bug goes and hides. When it comes back, it is so big it folds over on itself. Your T cells may recognize it, but your B cells won't. They don't know what to do with this thing. They try to build a new immune response, a new IgM, and the bug changes again. So that's why we get people continually showing IgM late in the disease. Now, one of the other issues that we've got, which makes this test even worse, is that the target antigens, according to Jennifer Halsey, and she's right, may not even be the right ones. Huh? We're not looking for the right bugs? Well, not necessarily. What's happened is, at 2 pharmaceutical companies were at that meeting in Dearborn. SmithKline and bioMérieux were chasing to build vacuum. They were both trying to build vaccines. The 31 OSP was the one that the vaccine for SmithKline got to the market, called LYMErix. And the 34 never got to the market, but that OSP band was being used by bioMérieux as they developed their vaccine. And so the CDC, in their wisdom, took those 2 out of testing because we knew how often they appear, and we don't want people who've got the vaccine, because everyone was going to get the vaccine, to always have a positive lab test. But if you take them out, other antibodies will show up, and the positive will then become from other antibodies. Yet these are the 2 most prominent antibodies that the patient's immune system develops. We knew that. SmithKline knew it. bioMérieux knew it. One of the tricks, but they took them out, because if you got a lab test back, if you ever got the vaccine, you'd always have a lab test. Those of you who were around back in the 90s when the vaccine became available in 96, taken off the market in 2002, the SmithKline vaccine required 3 shots because no one knew how it was going to work long term. It was rushed through CDC approval and FDA approval, and we found out later on that it didn't hold up quite as well in a lot of patients, and Lyme arthritis became the issue. So now, it's not just me saying they should have left this in. Those of you who have heard of Gary Wormser, this is from his direct statement less than 3 years ago. Many laboratories omit 31 and 34. These 2 bands are specific for Lyme. So you take 2 of the 5 major bands that are specific for Lyme out of, and this is the American Journal of Medicine. It's not New England Journal of Medicine, but it's a good one. And when Halperin, Baker, and Wormser, 3 of the people who sit very strongly in the CDC camp and have caused untold damage to poor Lyme patients over the world, are willing to say this, we should kind of pay attention. So the CDC, of course, didn't. And here's what they said back in 94, and it still holds true today. If you have 2 of these 3 bands, 23, 39, and or 41, you have Lyme disease and an IgM active infection. Not 31 and 34, because none of the test kits sold in the United States, and there are only 2 laboratories left in the United States that do not use a kit. IGeneX, Stony Brook. Those are the only, or unless you know the CDC people, which I don't think any of you do, or you know Alan Steer and can get it up to his 4th floor lab at Mass General, he still uses his and looks for 31 and 34 in his lab, and so does the CDC, but the public can't get that if you send it to a Quest, a LabCorp, an MDL, a Mayo, an ARUP, or any of the labs in the country, because you can't get FDA approval of a kit in the United States if you include those 2. As of 1994, December, you could not get FDA approval. So when we built the MARDEX blot, and yes, we had my laboratory at University of Connecticut, outside there, we actually threw over 2,000 of our patients, known positives and negatives, at this blot to get its approval for the FDA, and that's the Mardex blot that Quest and LabCorp use today. We engineered out, again, I'm a molecular guy, 31 and 34 to meet the CDC criteria. So we knew what it was going to miss, but that's what the CDC said. IgG was even worse. No one knew what was going to happen long term, so they said, pick 5 of 10 on the right and you got Lyme disease. Well, we now know that those ones in green cross-react with a whole lot of other diseases. 41 is a flagella. If you've got bacteria in your body, it's probably going to be positive, give you a 41 band in either IgG and IgM. Okay? So we have to discount 41 and only put in part as being part of Lyme when one of the far more specific bands are there. So IGeneX uses all those 6 on the left, pick 2 of those. On the right, you've got to have 5 of 10 on the right to be a CDC. So how good is it if you do an ELISA and a Western blot? Well, in Steve Daimler's study, this was the first one. He repeated it in 2009, repeated it again in 2014 with the exact same results on close to 2,000 patients in Maryland. The right answer happens 3 out of 4 times if you don't follow the CDC criteria and you do an ELISA and a Western blot together. You're only going to get the answer 3 out of 4 times. So make sure you're not the 4th person they test, okay? First 3 are going to be right, the 4th one's going to be wrong. So this is a call I get from physicians all over the country, including Canada, Australia, and Europe. What is an indeterminate in your result? Well, here's what it is. Here are the patients, 2 through 7. 1 and 8 are controls. 8 is the positive control. So let's take a look at band 39, which is an absolute presence of an infection of Lyme. You have been exposed to Lyme if you have band 39 by us or anybody else. But what do? You know that band 2, this patient's positive. But what do you do about 3 and 4? That isn't as strong as the control. You cannot call that positive. So virtually every other lab in the country calls that 0. It's not there. It's there. There's something going on. What's happening is, in most cases, your patient's immune system is so suppressed they can't produce a strong antibody response. It's not strong enough to be as strong as our control. We have to call that indeterminate. We will not call that 0. But every other lab will, and when your doctor gets the test result, you get a negative test result, regardless of how many indeterminate bands you've got, how much presence there is. If they don't beat the control, it's negative. And as I mentioned before, quorum sensing adds to the system problems, and this is Alan Steer's work again, quorum sensing. Now, we now know, we call them the Burgdorferi sensu latu strains. There are a bunch of strains that we now know have very, very similar genetic and clinical symptoms. All of these can be there. We don't find many of them in the humans right now. We have finding this one, the Mayoni. I just got a call from Florida, and I'm pretty sure we got a patient with Andersoni down there. And the Californias we've seen, and of course, Willi-Burgdorferi, which is sensu strictu up there, which means only that one. Sensu latu means any of these strains, okay? So, to add insult to injury, these are the 7 we now know are a problem, and now we've got the real ugly haired called tick-borne relapsing fever, because this is the coming plague, okay? What I've described has been a wonderful little journey of this bug outsmarting us all. We've got a plague coming. And it's going to be here within the next 2 to 3 years, and no one's going to pay attention. It's the tick-borne relapsing fever glands. These are strains of Borrelia that we know are here. Dotani, I'm finding it in the southeast. Parkeni, we know it's in the southwest of the United States. We are seeing Miyamotoi up and down the East Coast. Peter Krause published on it in the New England Journal of Medicine 3 years ago. Now we're seeing it up and down the coast. We found, not us, the University of Maine just found 17 to 18% of the ticks in southern Maine are now carrying the Miyamotoi strain already. And it was only just found here in the United States less than 4 years ago. So we have got those. Now we know the Mayoni strain is here. That's the strain your guys right down the road at the Mayo found. And we know the 2 European strains. We know the Lone Star EI. I got to tell you, Missouri, they don't stop the ticks from coming north, okay? So we know the Lone Star ticks moved here, whether anybody wants to believe it or not. Unless you know of some ban they have on allowing Lone Star ticks in here, which they can't do. So they're here, and of course we know Willie Burgdorfer's is here. So we not only have the Lyme sensu lato strains, which are in green here, that are in bodies in the humans here in the United States. We now have these 4 underneath it, the relapsing fever ones, and they're going to be a problem. Okay? And relapsing fever is most often cured by this tick, which means it transmits it in 15 minutes to half an hour. If you like to go camping, I suggest you find another thing you like to do, because above 500 feet is where this Hermsii lives in campgrounds. What it does is this Orthodontus Hermsii tick comes out at night while you're sleeping, attaches to you, feeds off the host, drops off within an hour, and goes on its own merry way. You never even see a rash, you never know it was there, and it gives you a whole lot of wonderful problems, because Hermsii is the number, that's why they call it Orthodontus Hermsii. How bad is it? This is the CDC slide. Tick-borne relapsing fever is now an epidemic in the yellow states. An epidemic. It is over 25%. We're seeing a huge increase coming. Here, welcome to Hermsii. Welcome to Miyamotoi. They're here. This is the regular Lyme, and the Pacific Estet is moving here too. So all of these things are coming together, and it's going to get worse because no one's paying attention. The Borrelia miyamotoi strain is not getting picked up by any of the routine lab testing, okay? And here is the real kicker. When the mother and the father get together on the tick, if mom has miyamotoi, she immediately passes to between 1,000 and 1,500 of the ticks, her larvae. So they come out of an egg from 1 to 1,500, not 1 to 5 or 1 to 10 like you would see from a normal, one of the other strains. So this was positive mice by state, Connecticut, New Jersey, and Pennsylvania, and this was 4 years ago. They started looking back in 2009 at turkeys in Tennessee. We don't see Lyme. 58% of them had miyamotoi. Yeah, because the test doesn't pick it up. Okay? So miyamotoi infection in patients in the upper Midwest. Okay, this wasn't supposed to be here. Well, this is the Gunderson Clinic. And they published on finding, 2 years ago, 7 patients already with miyamotoi. It's here. Problem is, looks like, feels like, tastes like Lyme. You're going to have the fever, you're going to have the fatigue and the headaches, all of the regular routines. It's going to look like, it's going to feel like, and according to Brian Fallon, he's absolutely right. If they test for Lyme disease, it's going to come back negative. So you're going to walk in, you're going to have all these symptoms of Lyme, they'll do a test, it'll come back negative, and they say there's nothing wrong with you. It's all in your head. It could be relapsing fever, and more than likely in this state is going to be the horror show in about 2 years. So we now test for all of these things. The relapsing fever looks for all 4 of them, our panel, and our Western blot, of course, picks up all of the strains, Europeans, the sensu latus from the United States and from Europe. But we have to try to stay ahead of them. So what we've done is we got this really sharp little kid out of Stanford a couple years ago. We put him to work at our laboratory in Palo Alto. And we started doing recombinant proteins, which are absolutely specific. We took all the recombinant proteins from all the sensu latus strains of Lyme, put them on one, throw them onto one one piece of paper. And what it means is when you see one of these bands that we know are specific, 93, 39, 28, OSC, if any of those show up, there's been an exposure to Lyme. It doesn't cross with anything else. Because a lot of doctors will tell you, oh, IGeneX only gives positive lab tests. So does everybody else, though. They also give negatives. And the reason you get the negatives and the positives is the cross-reactivity with chlamydia, mycoplasma, and a host of other viruses and bacteria that all produce Definitely a lot of them produce 41, the flagella, but they also cross-react with the other bands that are semi-specific for Lyme. And when you don't have absolute specificity, because you build these up out of cell lines, you can't absolutely, that's why it requires more than one band. If we had a specific band that never showed up for anything else, we could say, oh, all you need is that one band, you got Lyme disease. We thought that was going to be with VSLE1 back when Alan Steer first published on it in the early 90s, but we found out that wasn't it. They thought the protein C, which is the test that's used in Canada, the C-peptide assay, was going to be the panacea. Didn't prove it. The bug has different ideas than us. So, the immunoblot testing we've got so far, done with the CDC's help, shows that we have a sensitivity of 93% almost, which means if it's close, we're going to pick it up, and the specificity is even better. We're not missing for IgM, and we've had this on the market for about a year now. The guys such as Richard Horowitz, Ligner, Stricker, the biggest guns in ILADS are using this routinely now. This is the test that actually steps way up. It's like going from an Apple I phone to an Apple X. It is picking up. Nobody gets there. We have, and this is with CDC samples. So, but there's still another issue we've got. Because if your immune system's being shut down, you're not going to be producing, your B cells are not going to be producing antibodies. It's just going to shut it down, and you're going to get weaker and weaker. So, here's what happens when a bug gets into your body. The first thing it does when you bite is your dendritic cells, which are right underneath underneath your skin, see this thing that's not supposed to be there. They grab it. We call it ingesting it. Okay? They suck it in, tear it apart, and pass it off to your T cells, which T cells are going to drag that back. Part of it, their T cells are going to go actively right after it, just like your natural killer cells. They're going to go right after that bug, right at the site. But some of them are going to send that knowledge that they've just acquired from ingesting this bug back to your lymph nodes and have a B cell response, so you will build antibodies later on, 4 weeks, 5 weeks. This happens in the first 2 to 3 days to a week post-bite. So if the patient used this early on, T-cell response testing would be able to pick up Lyme at day 2, 3, 4, 5. But that's not where I think it should be used. This is where it should be used. When that bug comes back out of your tissue in hiding, it comes back into your bloodstream. Now you've got macrophages, which float all over your body all the time. Macrophages do the same thing as the dendritic cells. They grab the bug, ingest it, tear it apart, send the information to the lymph nodes, but the T cells activate NKs and themselves to go after the bug right there, right then. They don't wait for the immune system cascade to kick in. They're going to immediately go after it. So you're going to see a T cell response, which is actually giving off interferon gamma to force a release of other T cells and maturity of them to produce a lot of immune response. So in a T cell response test, which we call the IGeneX spot, there are a couple companies that do this. It will actually look using specific antigens. There is the kicker. You have to make absolutely sure that the antigens you use are absolutely specific for the disease you're looking for. So we use recombinant proteins again for decorin binding protein. We did not do the basic work here. Okay, Ray Datweiler and his group at Stony Brook did. It's a wonderful study that they just published last year of how good the DBB1 and A are. We do know that the outer surface C is very big in Lyme. We know A is. The VSLE1, that's the one that Alan Steer did a lot of work on being capable, and it does pick up some cases of Lyme at different stages. So by using all of these in our test, we are able to see if the body is going to release interferon gamma in the presence of a Borrelia infection. So if there's an active infection, when you combine it with a Western blot, we're going to know, because we're going to look at the T cell response and we're going to look at the B cell response. This test works pretty good. Sensitivity is not as high as I'd like it. Specificity is very good with ours. With a couple of the other tests, they use a different binding. They use a couple different antigens that I have problems with their specificity. So all of these things are wonderful. The next test that we could use, of course, is why don't we just look for the bug itself? Well, I showed you why you can't. It hides in the tissue. So you do a PCR test, and it comes back negative because the bug isn't in your blood, it's hiding in the tissue. It's waiting for your immune system to get suppressed. It'll send out some plasmids, some blebs. When it sees your immune system isn't doing anything, and that's when it'll kick into gear. Okay, so there's direct detection, and as a molecular biologist, if it's near to my heart, and we're looking for a needle in the haystack. That's a Borrelia. So in direct detection, we not only try with PCR, we have a dot blot, we try culture, we try a $3 million microscope, we even try FISH looking for RNA. It doesn't work because you're looking for the needle in the haystack. Okay? So, but we do have some studies done by Bayer et al. And others back in, from University of Michigan, and it actually showed that a PCR test in urine seemed to work pretty well when they did their studies. And PCR is nothing more than taking the DNA, denaturing it, which means we pull it apart. We cut that pieces up. We then use these things called primer sets, which are very sticky end DNA, and they will attach to those little pieces of DNA that we've got. We throw that whole dang thing into a lovely thing called a thermocycler. That's what Henry got the Nobel for. And it makes an exact mirror image. So you go, 1 makes 2. Do another cycle through the thermocycler, 2 becomes 4. Do it again, 4 becomes 8. For HIV and hepatitis, a PCR laboratory, molecular lab will do 25 cycles. Most laboratories do 25 cycles for Lyme. We use 3 sets of primers looking for 3 pieces of DNA, and we do 50 cycles. Is it great? We call it multiplex. Yeah, great. Does it work? Yeah, it's okay. If you've got a person whose immune system isn't working, this has been the test of choice because Borrelia is running amok. There's nothing to slow it down in the body, so it's going to fly around. You can pick it up in the blood or in the tissue. It's really good for cerebrospinal fluid or tissue. So it's highly, highly specific, too. If you got a PCR positive test from any clinical laboratory in the United States, it's not going to be a false positive. They don't allow what we used to do at MIT and eat our lunch on the tray next to the molecular. I mean, they stick it in a machine that Roche and PerkinElmer got very wealthy on, and it works, and it doesn't cause false positives. There are too many controls as standard. It is absolutely specific. It only happens when there is Borrelia there. So I do have a lot of doctors who are always under the gun from the IDSA guys who want to use a PCR because you can't argue with the DNA. Those of you who watched Henry Lee at the, during his talks with, during the O.J. Simpson trial realize that the DNA is the DNA. I helped teach Henry Lee back 100 years ago at MIT, came up to learn his PCR. But it's very specific, but its sensitivity is low. Why? Because it's not in the blood. It's hiding. You're lucky if you can catch it in the blood. Less than 30% of the cases we have ever seen from my labs down at outside the NIH in Gaithersburg, my lab at BBI at University of Connecticut, and out in everywhere else I've gone, and all the studies I've looked at over the years, show that this test works in about 20% of the cases of the patient. So you got an active infection, you're only going to pick it up in 20% of the patients. Okay? So it's because it's hiding. Here's a study from Schwann and the guys at the CDC, way back in '88, showing that Borrelia in the urine is where it's at. It's in the bladder. If it's anywhere, it's only 13% of the time you find it in the blood. So the guys down there, Tom Schwann and his group, developed what they call an antigen capture, where they actually look using polyclonal antibodies at at those specific proteins, and throw them into the urine of a patient or an animal, and look for an immune response that happens, and it causes what we call an immune blot forming, and you get a positive test. Is it good? Yeah, according to the guys at Stanford Clinical Lab, the specificity is pretty good, about 89%. We added 23 and 39 to those other 3 from the CDC, raised the sensitivity and specificity. Problem is, if the patient's immune system's working at all, what they're doing is the immune system grabs that bug as it's floating around in the body, and it encapsulates it. Okay, your antibodies don't kill it. They encapsulate it and raise a red flag, and then your macrophages come and grab the whole thing and drag it into your urine. Well, if that's already been done, because there was a little bit of an immune response, all of the surface antigens of that bug in the urine aren't there. They're covered by the macrophage or the antibodies. And now the polyclonals that we put in there can't find anything to bind, it comes back negative. So if the immune system's working, this is not a good test. But we do find it in people whose immune system is a wreck, doesn't work at all. This test has proven very helpful to a number of people who have been very sick and then finally diagnosed. So what do you want to do? Well, if you got a whole lot of money, you can do what Dumler does and test everybody for everything. But we've looked at this over time now at what works and what doesn't over the course of time of therapy of patient's disease. And here's pretty much where we can stand today. In 4 days to 6 weeks, very early, you should get an IGeneX spot. It's going to go away, I think, in about 2 to 3 weeks after a bite. I don't think the IGeneX spot's going to stay positive. The dot blot may be there a little longer because of the urine. After about 6 weeks, the bug's starting to disseminate. When that happens, you need to go to a test looking for your immune response, which is, and you can go to an ELISA, but don't. You can go to an IFA. You can try PCR, it might come back. A Western blot or an immunoblot's the right way to go. This is where, and I can tell you that we are really excited about the specificity and sensitivity of that immunoblot, as you saw. And once your patient gets severely sick and they're chronic, the patient's no longer producing a lot of antibodies. That's where our immunoblot shines. Sensitivity of the test is very good. And you can use a whole lot of other things as doctors try to make the clinical diagnosis into a lab medicine. When the immune system gets really suppressed, well, this wonderful little bug blows up. First thing that happens when the body sucks in, when the bug sucks in out of your body. The temperature difference causes what we call a couple of the interleukins to come to life. When autosurface protein A converts in the midgut of the tick, it starts to produce. An average tick that hasn't been feeding only has about 500 to 600 copies of Borrelia burgdorferi in its midgut. Once it starts to feed, the transfers to OSP-A to OSP-C, this is really eloquent work done by some guys up the road in Fort Collins, it multiplies out, and within 24 hours, there will be 100,000 copies of Borrelia in the gut of that tick, or already being pushed into the host in that cute little bubble of blood. And along with those things come all of their co-infections. And we have seen a boost, a high number of co-infections coming out now. So not only are we seeing Babesia and cat scratch, which is Bartonella, we're seeing the Ehrlichia anaplasma, Rocky Mountain spotted fever, and of course, mycoplasma. Here in your state, cases of other serious, less common diseases have increased in numbers. That's from your Department of Health. So here are the ones I'm going to warn you about most here. And I put in Powassan only because there were, I think, 28 cases here over the last 10 years. But the ones you really don't, you can worry about anaplasmosis, but if they think you've got Lyme disease and you actually get a good treatment, appropriate treatment of antibiotic, and I don't mean a subnormal dose that your doctor wants to give you, okay? Doxycycline is bacteriostatic at 1 or 200 milligrams a day. So the IDSA guidelines say use a bacteriostatic dosage. If the person's immune system's suppressed, it's never going to kill off this bug. The bug is too strong, too big, and too smart. You need what's known as a bactericidal dose, and that's a minimum of 300 milligrams a day, and you better go for a month. This bug lives for 25 days in its life cycle. Yeah, and it reproduces in 24 hours, but that is way too slow for doxycycline. Doxycycline likes bugs that quickly reproduce. So a high dose of doxycycline will most likely help most people. Later on, though, because doxycycline can't break the cell wall, when I showed you how the bug goes into the tissue and hides, the doxycycline can't break a cell wall. I mean, we'd throw tons of doxycycline on a petri dish filled with Lyme, and it looked like they were back swimming in it. They could just backstroke. You need to have something to open up the cell wall, and that's why we have cocktails now used by most Lyme literate doctors, where they'll use, in the case of a naturopath, they'll add cat's claw. In the case of an MD, they will usually add either Plaquenil or Flagyl. Those will loosen up the cell wall and allow the Borrelia-killing doxycycline to get in and kill it. Okay? So that's why you get cocktails, because you're not only going after the different stages of Lyme, you're going to get it through the cell wall. Okay? So here are the biggest co-infections, and I don't recommend you do a lot of testing for a lot of these, but you got them here. This is from your Department of Public Health. These are the ones they see here. transmissions of Lyme, Babesia, Anaplasma, Ehrlichia, and of course Powassan. So anaplasmosis, if you walk in and your head hurts because it's right behind your eyes, it's like someone with an ice pick, that more than likely is not Lyme. It is Anaplasma or Ehrlichia. Okay? Low white bug count, abrupt onset, those things are going to happen. The one that's not going to happen with Lyme is muscle soreness. Lyme likes joints. So it's going to go after your joints. But if you've got a muscle soreness that's coming and staying, it's probably a co-infection. You probably still have Lyme too, and this is the opportunistic infection that's coming along with it. So less common, rarely causes a rash. The one that's most scary, of course, is babesiosis. This parasite kills, okay? And it is insidiously becomes a problem with Lyme because of its effect on a thing called interleukin-6. So while Borrelia goes after, the Sensu strains go after interleukin-10, this one goes after interleukin-6, so your immune system really doesn't know what's going on, and it is just sputtering out of control and not producing enough antibodies. Most of the people with Babesia will have marked night sweats. They will have a dry cough. They will be profoundly tired. And these symptoms usually come about once every 4 or 5 days. Lyme disease is more cyclic to a month or 3 weeks. This thing is every 3 or 4 days. So if you wake up with the night sweats that are just drenching and you've got a persistent global headache, please have your doctor test you for babesiosis. It is probably there. Now there's a lot of different tests you can do for it. You can do PCR, but you notice I put 2 strains up there, Macrati and Duncani. Your laboratory and your doctor, if you say I want to be tested for Babesia, they will test for 1 strain. The slides used at labs do not pick up both strains. So they're either going to test for Macrati or they're going to test for what used to be the West Coast strain, used to be called WA1, it's now called Babesia duncani. They're only going to pick for one of them. You have to demand that they test for both strains. Now if you don't want to do that, you can go to a thing called a Giemsa stain. And a Giemsa stain is actually where the doctor, pathologist actually, takes your blood, smears it on a piece of, on a glass, and what he gets is called a Maltese cross, and the parasite actually causes this beautiful little green glow, and that means you've got either of the strains of Babesia. Okay? The good news about this is when you have babesiosis, even the infectious disease doc at the hospital is going to believe you, especially if the pathologist calls up and says, I got the parasite all over this patient. You need to treat him. Then you'll get the Mepron and the other malaria drugs that you'll need for the treating of malaria and for Babesia. But be advised, this parasite often goes away according to Krause's group at Yale. So Peter developed, when he was back at UConn, using inflorescent in situ hybridization for this. What it does is look for the RNA of the bug, because I've actually had pathologists tell me, oh yeah, it's PCR positive, but that's dead bug. Doesn't matter. They don't have active infection. They got the symptoms, then they got a PCR positive, but it's not. So Peter developed this fluorescent test, which is RNA. RNA is only live bug. Can't be dead, okay? Once it dies, it's gone. This is live bug, okay? So you can get it from Stony Brook, you can get it from UConn, you can get it from Yale, you can get it from Mass General, you can get it from IGeneX. Okay, Bartonella, this is the one that's always missed. Neurological issues, central nervous issues, go hand in hand with this thing. If your feet or arms burn, hands burn also, for an hour in the morning or at night, it's highly probable it's Bartonella, what we used to call cat scratch. And tender skin nodules, outer extremities right under the skin will have little bumps. That's more than likely a Bartonella infection. Okay, and again, the encephalitis, that's increasing in the brain. Irritability, anxiety, light night sweats, they're not as heavy as you get for Babesia. Bartonella 101, these are the rashes that show up with it. This is why we call it cat scratch. That's Bartonella 101. And right behind your knees, those are not stretch marks. Those are going a different direction and they're raised. That is a Bartonella rash. Most doctors don't look behind your knees because they have to practice 7-minute medicine. They only have time to look at their computer and ask you how you feel. and give you another prescription for something and send you on your way. But if you have a doctor who can actually spend 10 to 15 or 20 minutes with you, go through all the symptoms, therein lies the issue to want to have a filled out Richard Horowitz's game plan. Because when you walk in with the questionnaire completed, put it in front of your doctor, it'll only take him 2 to 3 minutes to look through it. Whereas if he asked you all those questions, it'd take him an hour, and his medical review they'd kick him out. So I'm going to warn you about one other thing here, and that is the 27 cases that you've had in the last 10 years of Powassan's or West Nile. And it's Powassan's virus up here. But I put them up there because the symptoms of both are the same. You'll get that fever and the headache. Again, it looks like all these other diseases, but usually the person is vomiting. Okay, Powassan virus is a real problem. The only people that you can get testing for it here in your state, and no, they don't do it at Mayo, they send it out, is the State Department of Health. Okay, so the Minnesota Department of Health will test for Powassan and for West Nile virus, and hopefully you don't have the encephalitis or meningitis, because it has been fatal. So the co-infection list keeps growing. Every year it seems that we find something new hanging around in this wonderful little monster that is spreading it like the plague. Again, I mentioned the free download from Horowitz's lab or his website at cangetbetter.com. Remember, there's a lot of bad things that live in the woods, not just the coyotes or the bears or the snakes. The ones that are going to hurt you the most are the ones you can't see. Sorry to say that, but it happens. But the good news is we have captured the tick. This tick was found in Pennsylvania, and that's one of my reps who caught it and dragged it back to the lab, and we are now testing it. So look, every lab in the country will tell you, IGeneX does a bad test. We do a test better than IGeneX. We're better than they are. I'll tell you what, I can tell you one thing from me. I do testing as good as IGeneX, okay? I can't make that statement for too many other people. So I got to thank you for listening, staying awake. The most dangerous test results are false negative, and most of the paths that people go down in your state and everywhere else is because they start out with a bad lab test, and that runs them down a path that you got to try to avoid. So thank you for listening, and I'll take some questions now. Okay. Sure.
Hi, so we did the Ellie spot in Germany.
Uh-huh.
And is that similar to what you were mentioning as one of your?
It's similar, but what they do, a couple things I worry about that. The sample integrity has to be very strong. If it didn't get to the lab within 48 hours, I don't trust the result. I also don't like one of the triggers, I call them, for the release of interferon gamma. See, what happens is when the T cell gets activated, becomes mature, it goes looking for and releasing interferon gamma to make more of it to become mature. You use specific triggers, like we use the DB1, the VSLE1, absolutely specific triggers that are well published on. Test in Europe uses one of those proteins called the P100, which we know crosses with a lot of other diseases. So you're going to get more positives with them, okay? So if you get the sample there in time. But again, it's got to be there within 48 hours. If it isn't, that you need whole blood, and that blood's going to break down, and you're not going to get a good interferon gamma release if you've got active infection. See, the good news about this T cell response test, and they've been used in neurology for years, is that a T cell stays active for 5 to 6 weeks. That's it. Then it dies. It's gone. So unless you have active infection, forcing the T cell to reduce the interferon gamma, you don't have an active infection. That's what the good part about it is. Now, Armin's laboratory does a nice job. If you get it there early enough, I will argue with Armin to the day I die about that P100, because there are a number of publications out there that show it shouldn't be used. But if you got a positive and you got treated, that's better. The worst thing that can happen to you is you can clear up your zits by taking a lot of doxycycline. Stay out of the sun. Okay? Sir?
I spent four different cycles through the hospitals and being locked up in isolation this time last year. And my specialist suggested that you put your foot up and have a blood smear for the babesia. And that was one of the 20-some tests they did that day. They came back negative, but they said, no, you don't have it.
See, what happens in the babesia test that you got, were you on antibiotics or anything before then?
Oh, yeah.
Ah. So what happens is babesia hides too. So they did a smear looking for the active bug for the fish test by smear. That's looking for bug in your blood. And Krause and others have published on that it doesn't take long, 4 to 5 weeks after an infection, babesia is going into hiding too. That's why he developed the fish test, because it's about 100 times more sensitive. So if there is any RNA running around, you can usually pick it up. Okay? They don't do that at the Mayo that I'm aware of. They use a very basic smear. Okay? Yes?
We have like quick tests for dogs.
Yeah.
Why does that work for dogs?
Well, look at their immune system. You know, people always ask me that. Why don't we have the vaccine? Well, you want to live for 15 years? Your immune system's a lot more complex than the dogs. Okay? So the vaccines that we give to dogs don't get lawyers involved. The vaccine we gave to humans during the 1990s into 2003, SmithKline got a lot of lawyers involved. People thought they got rheumatoid arthritis, Lyme arthritis from it, and the out-of-court settlement was to remove it from the market. A lot of lawyers got rich. So that's why we don't have a vaccine for humans. Now, they're developing a couple in Europe, but as I said, tell people, 74% of all the lawyers in the world live in the United States. It's going to take a long time for any vaccine to hit the market in this country again. Okay? Yes?
If you have a patient that's presenting with linear rashes that's suggestive Bartonella, what type of testing would you suggest?
I'd suggest you start out with an IFA, as long as they haven't been on an antibiotic. Now, the Bartonella test, I'm going to suggest you either use IGeneX or Galaxy Lab. Both of us do a good job. If you want to go to Galaxy, I think Galaxy does maybe even a little better than ours for Bartonella. Do not send it to one of the major laboratories. The slides for Bartonella come from one company, and that one company's Bartonella slides are horrible. Okay? We also do fish testing now for it, which is looking for the active bug. Some of the Lyme literate doctors will tell you that's the test of choice now, but Galaxy does a really nice job with their IFAs, so you could use them. They're in Maryland.
Can you kind of touch on how IGeneX is working with insurance companies now?
Oh, yeah. We're, I hope he brought in a couple of the forms. We have now, in an attempt, we cannot, none of these insurance companies want to deal with us. Okay, they don't want to, will not become a supplier, one of their normal suppliers, because they're going to go to Quest, they're going to go to LabCorp, they're going to go to ARUP, they're going to go to MDL, they're going to go to one of the huge labs and bundle everything together and drive the price down so they compete. They don't like to use individual small laboratories like ours that focuses on a specific disease. They want everything at a super low price, and the insurance companies drive that. Okay? So the insurance companies get them to do this. We are now have been working with or trying to work with a number of Blue Cross Blue Shields and other insurance companies across the United States where we will help the patient by helping them by giving them a literature, putting together rather the information and submitting it to their insurance company for them. We'll actually become their advocate for them to get reimbursed for testing. We are a Medicare provider, so if you're Medicare, you're all covered right now, so that's not going to be the issue. But for people who have got private insurance, get some of the forms from Johan. Johan's got some. Okay? Thank you. We're trying. Okay, sir.
You said Lyme decreases immunity or can decrease?
Oh, it does. It absolutely does.
Can it affect other systems?
Oh, sure.
Like thyroid?
Oh, of course. We see adrenal issues all the time with people with Lyme disease. It spreads out. It's starting with the immune system, but its ability to, your immune system runs throughout your body, does a lot of other things, and keeps, things like your thyroid and your adrenals running well because they protect it. When those protections go down, predispositions to other diseases start to show up along. A big issue is, the adrenal. So yeah, thyroid function can be affected for sure. Okay.
tested the urine push test where we did an ultrasound on her, and then it came back positive to babesia. Would it be a good thing, would it help me at all to do your test on top of that?
No, the patient has babesiosis. Treat him. Save your money and do treating. Okay? I'm glad it was the babesia one. I'm not at all impressed with their work in Lyme. I am impressed. Well, the babesia, it's kind of hard to mess that up. There's only a couple different sets of primers that work, and that does work. So, good. I'm glad. I'm sorry you got the positive test, but I'm glad you did.
She has others, like, would they have missed other steps? So
Oh, yeah.
we would really be better off.
Well, with the positive babesia test, you're going to need Mepron or other malaria drugs. So are you being treated by an MD who can prescribe those?
Yes.
Okay. And if he is prescribing those, he should be okay. Not knowing the specific symptoms and how long the child's been affected, other things that could be going on, there's a high probability there is Lyme there. And if she hasn't been treated for Lyme and you're just using the Mepron or the malaria drugs, the Lyme's still going to be sitting there when you've got the parasite of babesia out of the system. Sir?
My son was diagnosed with tick-borne disease and was treated for quite a while with kind of a cocktail of antibiotics.
Sure.
So, and now at this point, the doctor has moved to a new therapy. He's just begun called LDI, low-dose immunotherapy.
Yeah.
Can you comment on that at all?
In patients who have been chronically ill, it appears to be working well. Trouble is, until I see published studies, I try to reserve my thoughts on it. I have seen some of these things work really well, and the data so far looks good with low-dose immunotherapy. It really does. We've thought of other therapies that we thought were going to be great too that didn't, but this could be it. Okay? That's good. That's a good thing to move away from high-dose antibiotics after a period of time. Good.
There's a doctor, I believe he's in Colorado or California, that came up with this LDI. And
Yeah.
Dr. Foley gave me the link to it, and I watched his testing on it.
Yeah.
And I've done the LDI since January,
Yep.
and it is miraculous on
I
how
like-
it has helped me take
Perfect.
away my symptoms.
That may not be the panacea, okay?
No,
I just want to be, when people are very sick, they grab at straws, and I hate that. I refuse to be. So, but what I want to see is, I want to see third-party evidence. I know how good a job he's getting, and I hear a lot of it from people like you who have been taking it and doing well with it. I hear the same thing about a number of other technologies and other treatment protocols, and until I see third-party reviewed placebo-controlled studies showing it in another place that I have to reserve my thoughts. I'm sorry. But yeah, if it's working, don't stop. For God's sakes, the pelican's not supposed to be able to fly. Don't tell it.
You said that one of them is shed in the urine or in the bladder.
Well, we find that Borrelia burgdorferi will get shed into the bladder.
Does it cause chronic problems after that?
After it's shed?
Yeah, well, because it was shed in the bladder, and does it cause?
It's not in the bladder I'm worried about. It's a live bug hanging around. Okay, so usually it clears out of the bladder. That's not going to be your biggest issue. If you've got enough of it that it's hanging around in your body, it's other places, like the adrenals, the thyroid, and other places around your heart. That's where I'm starting to worry more. Okay. Sir?
Some
Another one?
places talk about irritable bladder with Lyme or GI constipation.
Yeah, a lot of gastroenterologists love to tell you that, that's caused because of all the antibiotics you're taking. I can tell you that as a person's gut becomes, I call it mucked up, your ability to absorb antibiotics goes away, your ability to absorb your blood, everything. As naturopaths often say, it all begins in the gut. So that's why many naturopaths who treat Lyme specifically clean out the gut first so that everything can be absorbed. You know, it's kind of like putting drugs into you or putting them into a pipe. If you put them into a pipe, they never get absorbed. You have to clean up the gut so that they get absorbed and actually can affect. And yes, we found over the years that Borrelia does have a negative, significantly negative effect on the gut's flora. Okay. Okay, thank you for listening.
Well,